Today we're going to talk about vulnerable patients, and we'll go through a number of items. Some of this we've talked briefly about before. Split this up into two parts because of the size of the amount of information that is available. Before we start, as everyone is well aware, we do have some weather heading towards North Carolina for those of you that are in the state of North Carolina. I hope everyone is safe and that you wind up being okay. For those of you that are outside of North Carolina, just please note that some of us may be in a position of not having electricity or power or some other things not really supposed to hit until this weekend. But just letting you know in case you do try to reach me and I'm not able to get back to you right away, please hold in there for a couple days, depending on the situation, how things go. So everyone be safe. So part one, we're going to talk about a variety of different areas, but specifically let's start with some definitions of really a vulnerable patient is someone who is susceptible to attack. And it really has something to do with the dependency of the person themselves and the inability to give consent. So a question can be raised, is everyone vulnerable in some way? And the answer to that is yes, in some circumstances. However, we need to have some way of saying that there's a group of people or a group of patients or whatever term you like to use that really needs special protections. And what can we do to provide ways to minimize vulnerability and minimize risks based on the ability for someone to really consent to the area of looking at clinical research. There's a number of groups that are looked at. Fetuses, pregnant women, prisoners, children. We've probably focused more on the children's side than anything else. People eligible to be included in emergency research, which we've talked about, and also had some information through Blackboard and discussions looking at that specifically. So we'll take a look at a couple of these just to highlight this. It is interesting, groups without special protection. And although this is shifting, with dementia, people who may be delirious, developmental disabilities, mental illness. And so it brings to question is, should all psychotic patients be considered vulnerable? Depending on how they are, what stage they may be in of a specific disease state. As an example, one of the cases that we had talked about a woman who gave consent and then in the evening was very confused and didn't understand what was going on and why they were trying to do things, and while she consented during the day. And I'm not sure how many of you are aware of something called sundowning, but I wanted to bring it to your attention because it's a unique item, normally in elderly, and it tends to happen more in situations where people are outside of their normal environment. So we talk about that being a hospital or something of that case, where as the sun goes down, the term sundowning, a person can become very agitated. They become someone other than themselves. Not able to think right. Even though they've been told many things, they don't remember them at all. And if you've ever had a family member with this, it can be very, very difficult and can fully understand in the case why the researchers were having the issue they were having. And I would suspect that within that case, this is a situation where, the patient presented during the day perfectly fine. And then after a dinner time, all of a sudden things shift. And, some places to correct this, try to keep lights on, as many lights as they can in a room, as long as possible, things of that nature. So it's interesting part of that, which would bring to the question is, could you actually ask someone in that phase to be included in a clinical trial? And obviously the answer is no, from a standpoint, they don't have any understanding, even recollection of what happened at the night before from that standpoint. So as we continue, we take a look at some other areas, as people who are economically disadvantaged, or even if you want to say people who may be educationally disadvantaged, may have limited literacy or language skills. And these are things that we talked about briefly the idea from an informed consent document being written at a specific level, people with literacy issues and trying to work with them, trying to see how we can really help from that standpoint. An example that I think is interesting from colleagues that we've talked to is, we understand if someone's traveling to the U.S. and they get sick and they've been in the hospital, that the goal is to find someone who speaks the language, and we can just think about that as the reverse. Let's say you are traveling somewhere in Japan and you became sick and you couldn't read or speak Japanese. You're in a rural hospital area. They're having difficulty finding someone who speaks English. Is that considered a vulnerable group? And so there's a number of items that we look at, some that are considered vulnerable and some that are not. So when we look at it, the concern we have from a factor is the authority over the subject. So as an example, military personnel being vaccinated. Some would say military personnel would not be considered a vulnerable group. Basically, as they sign up for serving the military, they sign specific documents that say that, they will follow the rules and regulations, and one of them would be vaccination, depending on where they may be deployed to. That's pretty tough. Prisoners, it used to be clinical trials were done with prisoners for years. That obviously has changed. There was a lot of coercion to get people into those items. There were a lot of favors given if you participated, from that standpoint. Students whose professors do research on them, as part of a class or a part of something else. Kind of tough to say no in that position. So it's interesting to see how we do that. And obviously women in some societies, culturally can be in a very vulnerable position that others would say what they have to do from that standpoint. And it's the ability to understand. If we think about this in children, and in children we have another entirely different area to look at, specifically ages. We talk about a child who may be 3 years old really wouldn't necessarily understand items. Does a 5 or 6 year old have some understanding depending what the trial is? And adolescents and teens, where do we place them from an understanding capability? Persons with developmental disabilities or those who are heavily medicated, a whole variety of items that can really affect the ability to understand the process that we're going through. And then the medically vulnerable, those are too sick to consent. Fear of displeasing a physician is really shifting. For those of you that may have, depending on your age, grandparents or great-grandparents who are in their, let's say, 70s, 80s, 90s, the culture back then was whatever the physician said is what you did. You did not want to displease them. So that is changing today from that standpoint, but that has been there for quite a while. So I'd like to focus a little bit on children, and I'm going to go back a little bit more than 10 years, about 14 years ago, when the Institute of Medicine was charged with getting definitions of minimal risk with respect to healthy or ill children. And the reason I want to do that is things have changed over the years, but I wanted to go back to give you a little bit of the history and how this was initially started. And you may be shocked to realize that it was in 2004 when it started. You may have thought it was much earlier than that. But this is really when the charge was put together for the organization. And, trying to define items such as minimal risk, the magnitude or probability of the harm, and in some cases, discomfort. And as I just mentioned before, it's considered in relationship to age and, duration of potential harm and what's happening. So we have to take a lot of things into consideration. And it doesn't matter if a child's healthy or ill, the same level of minimal risk applies to both. Higher risk is not acceptable because a child is ill or lives in an unsafe world. And you can define an unsafe world whatever way you would like. If you want to talk about an environment that they're in, if you want to talk about being in a third world country, whichever way you feel provides an understanding of how you can interpret that type of information. So the committee recommended to the FDA that research on minors, sponsored by the FDA, will be submitted to the FDA for parental permission. So in other words, you have to have some type of a provision for parental permission. And they felt that they needed to revise the regulation and permit waivers, which we've talked about, but we haven't talked specifically about waivers for parental permission consistent with other Department of Health and Human Services regulations. So parental permission waivers, if we come back to talk about IRBs, they can consider waivers of parental permission within research if it is important to the health and well-being of the adolescent and it's not feasible without a waiver or involve treatment that states allow without parental permission. So now we're at a position of being a national company doing clinical research, and we do have to take a look at the state regulations of each state and what they allow and what they don't allow for different aspects if we are doing a clinical trial that's related specifically to some areas that may be included. So we have the two items, and we add to that, the investigator presents evidence to the IRB that adolescents can understand the research and they have the right to participate, and that the protocol includes appropriate safeguards to protect adolescents consistent with research risk. So let's think about this for a couple of minutes here. I mentioned before the differences of a 3-year-old to a 5-year-old or 6-year-old to a 12-year-old to a 18-year-old who is considered a minor from an age standpoint. And there's a couple items that come to mind from an ethical area, and these become very difficult to consider. And this is where, in a graduate level program, I always like to ask this kind of question and really have you think a little bit through the process. So let's say we set up a clinical trial. And actually what we're really doing is we're trying to get some benchmark information on healthy kids who are 6 years old compared to kids who are six years old with cancer. And what we're trying to do is basically do some research on the blood work of each group, the healthy and the children with cancer. So what we're looking for in this specific area is to do a finger prick and just get a small amount of blood that will allow us the opportunity to take a look at it and study some items. If we find specific items, we may move to the next level a little bit more from that standpoint. But let's just look at it from a standpoint of basically a finger prick. The idea of someone who is diabetic who does this all the time to test their own blood for sugar, but this is different. We're talking about a 6-year-old. And when you have a discussion about this with a group of people, you will find people on both sides of the argument here. Some people would say that you can talk to a 6-year-old and explain to them, and this is the healthy 6-year-old, and explain to them that we're asking them to do something that does not help them at all. And kind of what we talked about on the midterm exam a little bit is healthy volunteers have no benefit at all to what they're doing. So here's a 6-year-old that you're talking to and saying, what we'd like to do is do something to your finger that will make it bleed a little bit, and we're going to collect that. And then we're going to take a look at what's inside there to see what you have compared to another 6-year-old who has cancer. And we're trying to do this to see if there's ways we can help the child with cancer. So you're going to have a couple different positions on this. You're going to have some people who will say absolutely not. A 6-year-old cannot make that decision. They don't have the capability of making a decision. Why would you put them in that position? That's something a parent should be saying or doing. On the other hand, you have others who will say a 6-year-old is perfectly capable of understanding that one item. And if a parent signs them up to do this and the child says no, then in fact the child should have the capability of saying that. So we have this kind of discrepancy that we look at when we're talking about children and how to go through that process. So that's one example. Now let's go to the other side, where you may have someone who's in their late teens, let's say 17, 18. And there's a clinical trial that's being done for, let's say, a new type of hepatitis that has just been discovered that is becoming prevalent in 17 and 18-year-olds. And the idea behind this study is to get those, get blood samples so that we can begin to find markers and to test for this new hepatitis that has been discovered. So the question that comes up is, can a 17 or 18-year-old make a decision to not just do a finger stick type idea, but to actually do a blood draw and make a decision that they want to help or not? And again, we're going to run the gambit here, which may be surprising to some, of some parents saying, absolutely, yes, my child is capable of making that decision, to some are going to saying, absolutely not. That yes, my child is 17 or 18, they fully understand what's going on, but I make the decision regarding their medical care, and that's not going to change just because you're doing a clinical trial. So I bring these to your attention more from the standpoint of asking you to consider at what level for children do we think to be vulnerable, or at what level or age or education do we feel that they no longer fit that criteria. Now, the reason I bring this up is at the same time, I can say, let's talk to a 30-year-old about the same idea of giving some blood. They may not be any more capable than someone else who's 10, 15 years younger than they are. So it really is individualized to the specific participant. And so all this needs to be tailored to work with the individual from that standpoint. So I hope that gives you a little bit of some ideas to think about, some ways to process how ethics is going to impact a protocol that you may be involved in developing or reading or providing comments on. And depending on the age and the type of patient that's being recruited, you can begin to provide insights for the PIs and others as to what types of ethical concerns you would have to help them make the appropriate adjustments and add the appropriate wording within the documents themselves. That's the end of part one. I'll be recording a second part shortly.